afternoon. Thank you for joining us today at the Rehabilitation Hospital of Northern Indiana. For this month's topic of discussion, we're going to learn about orthopedics, wrist and hand injuries. Today we have the honor to have Dr. Fuller with us. Dr. Fuller, tell us a little bit about your background and training.
Sure. First of all, thank you for having me. I'm excited to be here and to share some information. I'm originally from Chicago, Illinois. I attended the University of Notre Dame and graduated in 2005. I then went back to Chicago to the University of Chicago for medical school, and that was a 4-year medical school program. I stayed an additional 6 years to complete a plastic surgery residency where I rotated through general surgery and plastic surgery. I then spent an additional fellowship year in Baltimore through an orthopedic hand and upper extremity fellowship where I really honed my skills on hand, wrist, and upper extremity. And then from Baltimore, I was recruited back to the South Bend area and joined South Bend Orthopedics 6 years ago, and have been very happy in providing to the community so far.
It's wonderful. Thank you. Thank you. What are some common hand and wrist injuries that we're seeing, especially in the winter months?
Yeah, and so the Midwest really has two different seasons, in my opinion, from a hand and wrist perspective. There's the hot season where people are active outdoors and there's a lot of higher mechanism injuries to the hand and wrist. And then the winter time, it's really just the slippery ice that is a huge deal. And so even this week in the office, I've seen several patients just with slips and falls on the ice, and that can cause wrist fractures, wrist injuries, and also finger fractures and dislocations. And so each one of those items need to be treated specifically to each individual patient.
Yeah, and what do those treatments look like?
Yeah, and so, for my practice, I try to treat each patient uniquely and individually, and it's really a team approach between the family members, the patient, and myself as what their goals are. If they're a high-level, high-performing individual, you want to try to return them back without any restrictions. And essentially, the assessment is both the physical exam as well as the x-rays or the radiographic evidence that exists. And so we'll actually take a look at it together. I'll zoom in on the pictures, I'll point out the fractures or the injuries, and then make sure that that corroborates with the physical exam, and then determine what their limitations are, what their pain level is, and then really give them options. I try to give each patient the option, steering them towards the choice that I think would be ideal for them, but ultimately leading to a team decision. And largely, specifically for finger fractures, dislocations, and then wrist injuries, including the distal radius fractures, it's either surgery or non-surgical, and that includes casting, splinting, or actually a surgery where typically that surgery is an outpatient procedure.
Okay. What does the recovery look like?
Yeah, and so, I'll talk with the patients and family that either we choose surgery or non-surgery, the recovery is the same. It takes about 6 weeks for the distal radius to heal or your wrist fracture to heal. And that can be in a cast for 6 weeks, or it could be in a removable splint or cast if the fracture is either mild or they've had surgery to internally stabilize the fractured pieces. The surgery, if that becomes an option and that's necessary just based on how bad the injury is, that is actually an outpatient procedure that can take as little as 25 to 40 minutes of time. A lot of patients are surprised by how short the procedure is and how short the recovery time is. Depending on the discussion with the anesthesiologist, they generally receive a nerve block of their arm, which drastically reduces the amount of pain that they have afterwards and the amount of pain meds that they need to take. And so it's not surprising for me for a patient to go home an hour or so after that surgery with very little to no pain, and they may be completely off of pain meds within 2 to 3 days. And so that surgery is really pain relieving rather than pain causing, because we're stabilizing the internal pieces and putting that back together with plates and screws most commonly. Generally speaking, if the patient requires surgery, I would be seeing them back 10 to 14 days later, removing stitches and then placing them into a removable splint so that they can begin to shower, to wash their hands, especially in this COVID period where that's so important. And then whether they need early therapy for swelling and range of motion control, but gently guiding them to that 6-week mark where we can start adding weight and lifting the restrictions.
Okay. So what other injuries do you see during the winter time?
Yeah, and so just looking back, I had mentioned that finger injuries are also very common. That can be either open or closed injuries. And so thankfully we haven't had too much snow this year, but when I'm on call, I typically in a heavy snowstorm will see snowblower injuries. And that's just people trying to clean out the snowblower, which is, kind of a scary thought to think of. And it's something that, you wish you kind of had a different option to clear that out. And those are typically surgeries that are performed the same day that it happens. You drive into the ER in the operating room at the facility and fix it. Other times for slips and falls, it really just depends on what takes the brunt of the punishment and the weight that it carries. I've seen a few finger fractures and dislocations just from ice skating, from slipping on ice, and just from tripping over surfaces that are outdoors that is covered by snow.
Okay.
And so
Interesting. Yes.
And the treatment is really the same for those as well.
Okay.
I would say many more finger fractures can be treated non-operatively, and that's always the goal. Even though I'm a surgeon, I enjoy operating. It's my passion. The goal is always what can we do from the least complex into the more complex, and if their exam fits the standards of care and meets requirements as far as their range of motion, the x-rays are within the normal parameters, the goal would be early motion, protected, and then just serial exams, seeing them in the office frequently to make sure that they reach their highest point.
Okay. What about arthritic flares?
Yeah, and so it's interesting in the winter times, typically cold weather, and having been in the Midwest my whole life, it's hard for me to know whether patients in Texas or Florida have the same issues, but I often see patients who come in thinking that their fingers are either inflamed, infected, where in fact they're having arthritis flares that tends to be worse in winter or cold conditions. And so that can come up as a swollen, painful joint. The most common joint in the hand and the wrist is the base of the thumb, and the thumb is really 40% of the function of the hand. And so when you can't turn a key, open a jar, button your clothes, you notice it, and that usually prompts treatment with a hand specialist such as myself. We'll get baseline x-rays, we'll discuss it. Most of the time we can navigate through with steroid injections to try to decrease the flare. And how I would describe the arthritic flare is that you have this arthritis, it's been brewing inside your system, in your musculoskeletal system for years, and then there's some inciting event, whether it's cold weather, getting out the shovel or snowblower and just kind of overdoing it for a few hours, and it wakes up this dormant volcano. And so it's erupting, and we want to try to make that volcano dormant again. And that could be either ice elevation, if no improvement, a steroid injection to calm it back down. Some patients ultimately require surgery for their arthritis, especially at the base of the thumb. It's one of the most common surgeries that I perform besides carpal tunnel and trigger fingers. And not a lot of patients know that there is a surgical option to correct that. It's been around for decades. And once you run out of the number of steroid injections that you're allowed to take safely, that becomes a bigger option. I also see a large portion of my older population wanting to have surgery this time because they don't want to be taking time off from their gardening, from their outdoor activities, from traveling in the warmer weathers. And so I'm seeing a lot of patients in January, February, March trying to get through the couple months recovery come springtime so that when they're ready to do their gardening and outdoor activities, they're ready to go with a new thumb with less pain.
Right. Now the question is, how has COVID affected what you do in your practice and surgery? And
yeah, I think overall, just as it has for anyone else, whether you're trying to take a younger child to school these days, as my wife and I are, and we're constantly battling guidelines and proper testing and safety. It's been over 2 years or close to 2 years of wearing masks every single day. I've actually had 2 patients this week ask me if I could step out of the room and lower my mask so that they can see my face. And it's just one of those things where at first glance, when I was first asked to do that several months ago, it caught me off guard, but really in our culture, that's important. You have this doctor-patient relationship, and I've gone through many traumatic, complex reconstructions and recoveries without having seen the patient's face and without them having seen my face. And so I don't want to say that I break protocol, but I do try to give them a little peek just so that they can understand, because as much as they can go on websites and look at pictures, they just want to make that connection with me. Otherwise, just more logistically, there's way more cancellations that we see either with exposures, close contacts, positive testing, and or patients just wanting to wait until different surges slow back down. And so there's just been a lot more work from our staff at South Bend Orthopedics to make sure patients are educated and aware of where testing sites are, what their quarantine mandates are. We have nurse practitioners and staff that are fully, their full job is to manage COVID by contacting patients with their COVID results, managing that. We have a COVID task force now at South Bend Orthopedics that's instrumental in just giving us updated guidelines every Friday. We have reminders to wear masks and what the current protocols are. And it becomes, ultra complex when I just had a post-op patient yesterday who had a close contact with a family member. So what do you do in that situation? And we basically would defer to our COVID team on whether it's a positive result, whether they have symptoms, how significant that was, and whether it's a 5-day delay or 10-day delay. And sometimes that requires us to have the patients go to an emergency room to have their stitches out, where there's COVID-protected masks and ventilation systems. Fortunately, that's been very rare, but those are the types of things that you really can't plan for or anticipate. And hopefully we get through this endemic with safety among the population and with less hassle overall for patients who need orthopedic care.
Yes, yes. Is there anything else that you see, especially in the senior population, with just being winter?
Yeah, and so I had mentioned in part of my training was through plastic surgery, and so I'm the only plastic surgeon at South Bend Orthopedics. I'm one of the 4 hand, wrist, upper extremity surgeons, and we all do a great job with the team approach. In my practice, I've also, for the community, have found that there's a need just to treat skin cancers and wounds. And so this is also the time of the year where a lot of the local dermatologists are completing their routine skin exams and finding and identifying skin cancers where the patients want treated. And so that's also can become 40–50% of my practice in few surgical days, where they have skin cancers just from sun exposure earlier in life, and some of their skin is very complex to close with different aging spots and more diffuse skin cancers. And so as a plastic surgeon, I welcome that challenge, and those tend to be very satisfied patients who can get back to what they're doing with minor procedures with excisions and closures. And so that's another part of my practice in the aging population that I enjoy and see on a daily basis.
Yeah. Well, Dr. Fuller, I want to thank you for joining us today, and just with so much education and insights, we thank you.
Thank you very much.